Hello and welcome to UVA's Medical Center Hour. I'm Justin Mutter, Director of the Medical Center Hour, a program of UVA's Center for Health Humanities and Ethics. We are delighted to see so many of you joining for our first in-person event, hybridized with Zoom. Since this is our first hybrid in-person session, let me just say a few words about the structure for our next hour together. Our speaker and our respondent for today have completed conflicts of interest statements and have no disclosures. Please also note that continuing education credit can be claimed for today's event. When the time comes to enter into the question and answer portion of the event, we will alternate between questions from the audience and from our Zoom audience. Those joining us by Zoom can enter questions in the Q&A portion on your Zoom screen, which will be monitored by me as our panel continues its discussion. So public health was never supposed to be easy. Human history is brimming with extraordinary social, political, and economic challenges brought on by both epidemic and endemic disease. Like medicine, public health in the modern era has had its wins and its losses, its successes and its sometimes egregious failures, particularly in the protection of marginalized communities. But our collective aspiration for the public's health was toward better science, clearer information, and greater community collaboration. While always a contested space and while always working to resolve its imperfections, public health has had a trajectory, a set of goals and understandings shared by a substantial majority within the public itself and among policymakers and politicians. The COVID-19 era has altered this landscape, perhaps more than at any other time of pandemic in history. Today, words like disinformation, mistrust, and dishonesty proliferate in the middle of the public square. This state of affairs has many causes and many catalysts, but certainly among them is the role of social media in modern life. What should public health look like in this context? What are its new goals, its novel paths to ensure healthy lives for all? Today, we welcome Dr. TK Avula, who is uniquely posed to help us answer these questions. Dr. Avula, a graduate of UVA's undergraduate college, has had a remarkable career in public health, currently serving as the director of Richmond City and Henrico County Health Departments for the Virginia Department of Health. He is also serving as the vaccination coordinator for the Commonwealth of Virginia. We will also be joined in the panel by Dr. Max Luna, Associate Professor of Cardiology here at UVA, who is also the director of the UVA Health Latino Health Initiative. Please join me in welcoming Dr. Avula.
Thanks, Dr. Mutter. Wonderful to be here with you all. For my few brave friends who have come to this first hybridized version of this, and then to all of you watching at home on your own time, it really is a pleasure and honor to be here. You know, this last 18 months has been unlike any time period that I think we as public health, certainly as clinicians, as healthcare institutions have endured or weathered, and ultimately will triumph over. But you know, this time period has been unlike any other. We've heard the word unprecedented an unprecedented number of times, and it really seems to capture the ethos of what we have been living through. You know, the title of this talk, I read on Twitter that I think you all have heard some version of this in your clinical practice from your family members, from your colleagues, whether it's a different social media platform of choice or the internet or a friend or somebody who may not have the credibility that you all do as trusted clinicians and experts in this field. And during this last 18 months, we have seen more of this than we ever have in our lifetime, skewing the kind of guidance and information that people are are trying to take in and trying to use to make decisions. And so it has been this extraordinary challenge over the last 18 months to try to advance credible public health guidance in this sea of a million voices. And it's interesting because in public health, we are really good at planning. We spent a lot of time over the last 20 years, really since 9/11, one of the core functions of the institution of public health was to engage in emergency response planning and coordination. And really it was kind of anthrax after that, and then the threat of emerging pandemics that public health has really organized their response around. And so we do a lot of planning. Every year we do mass vaccination efforts with the flu vaccine. Federal government provides a lot of funding for us to be able to stand up large-scale mass vaccination. And the whole point of that is that we practice the operations of vaccine delivery. How quickly can you get 1,000 people through, timing throughput, figuring out the most efficient way to do registration, figuring out what's the best way to do the observation period. And so that planning is a huge part of what we do as public health. But I'll say that piece of this response and that rollout, whether it was testing or vaccination efforts, went pretty smoothly over the last 8-9 months. I remember being at a mass vaccination event in the Richmond area at the Richmond Arthur Ashe. It's a convention center in the city. And there was kind of a grizzled old guy with a big bushy beard. And he saw me as I walked in, and he recognized me because I've done a little bit of TV over the last year. And he said, "Doc, I just got to tell you, this is the best thing I've ever seen the government do." And I wasn't sure whether to be, slightly jabbed by that or to really take pride in it. It was a little of both as someone who spent most of his career in government. But the fact of the matter is, and one other person said, "This operation is even better than Chick-fil-A." That one I'll take to the bank. But the point is that the operational side of our response was well practiced, well run, well executed. But what we could have never really planned for is the cultural and social and political context that this has evolved from. So we're great at planning, but how do you plan for this last year that we've had? And you think about all of the different themes that have emerged from whether is COVID real? Is it a hoax? Where did it come from? Was this intentional? Was it not? Guidance that shifted. Don't wear a mask. Now do wear a mask. Can we trust the CDC? And so on and so forth. And all of that overlaid with some really stark social and cultural happenings, right? Our country went through a really charged racial reckoning, and that was in the backdrop and in the forefront of all of these decisions that the public policy legislators, public health folks were having to make, and that the public were having to make as they tried to interpret all of this information. And so I think it is important for us to recognize that part of what has been so difficult and different about this pandemic response is this broader context that this has been happening in. So I want to just share a few examples of where that has been particularly profound. Testing is one that I'll start with. So back in April of 2020, this really broke in Virginia. March 13th was our first case. April of 2020, we started to see a significant expansion of testing. UVA, VCU, some other institutions were really scaling up their testing capacity. And then the state lab as well had increased access to PCR testing. Our efforts as a local public health agency really were focused on ensuring that testing was available as widely as possible, but with a special and particular focus on communities that typically do not have the same level of healthcare access. And so a lot of our testing efforts were geared towards going into lower income, predominantly minority communities and setting up shop to ensure that they had the same access and ability to determine if they were exposed or COVID positive or not. And I remember in advance of some of our work in some of our public housing communities throughout the city of Richmond and county of Henrico, we announced that we would be coming in and making it easy, making it more accessible, making it completely free. And the social media storm that erupted from this was really remarkable. Initially we saw things like, don't let the government come in and test you. They're intentionally going to be giving you COVID. Like we're trying to infect people with COVID through the testing process. And I think that smacks of a lot of the historical events that have shaped particularly the African-American community's experience with institutional public health and healthcare. And so that was a real response handed through real lived experience that didn't happen that long ago, that we had anticipated to some degree, probably not with the energy and kind of vitriol that we saw here. In addition to that, we saw a lot of the movement around, natural medicine or non-traditional care, and people saying, you don't need to know if you have COVID or not. Just live healthy, eat more vitamin C or vitamin D, or take your zinc. And so there was a huge emergence from some of our lower income communities around those themes. And then in Richmond, we've had this kind of complicated past few years of trying to make decisions about public housing redevelopment and how do we give low-income families opportunities to move out of concentrated low-income housing. And I will say there have been ways that communication has not gone well. There have been challenges to the way that connection with the community was made, but there were overlays of that seen here, because at some point, another theme that emerged was that as we go into public housing communities or other low-income neighborhoods, we're actually using COVID as a way to evict people and to remove them from their community so that we could proceed with public housing redevelopment. And so you just see that there were layers upon layers of distrust, of bad information, of myths that were being perpetuated word of mouth, through social media, through family units and structures, that became a real challenge to the work that we were trying to do in testing. Another example is what we've seen in women of childbearing age. This segment of our population, kind of across race and class, continues to be one of the most resistant to vaccination. And some of this, again, we could have anticipated, because around vaccination in particular, these tropes have come about. Every time we have a mass vaccination effort, polio, this certainly was a theme, HPV vaccination, and then we've seen it kind of come raging forward in COVID vaccination. And this idea that really plays on people's the unknown of the future and fear of what may happen, not having long-standing evidence, or because this was, by some accounts, a new vaccine, despite the fact that we'd been working on the mRNA platform for the better part of 20 years. But this idea that you would be introducing something to your body that has effects that we may not know about because they happen down the road is a real challenge, and was really inflamed in December of 2020 by a German physician who was also a local politician in Germany, who paired up with a former Pfizer employee, and they went to the EMA, which is Europe's kind of analog of the FDA, and they said, in our studies, we have seen that the genetic code, the sequence of the spike protein, which these vaccines are developed to recognize and act against, that there seems to be a lot of overlap between that spike protein and the proteins that exist on the placenta. And we really want you to not give approval to this vaccine until that's thoroughly studied. And that, just that kind of tossing that grenade of curiosity, of doubt, erupted on social media, and really has continued to be one of the major reasons that people cite for not wanting to get vaccinated, despite having numerous studies that show that there are no differences in outcomes between pregnant women who get vaccinated versus unvaccinated in terms of birth outcomes, despite geneticists and immunologists looking at that sequencing and seeing that there really is only about a 7% overlap between the spike protein and those placental proteins. And every other scientific way that could be debunked, it has been debunked, yet the unknown and the power of just that idea blossoming on social media has continued to pose a significant challenge. And then Nicki Minaj. So Nicki Minaj, who is a famous pop star, for those who don't know her, has a Twitter account with 22 million followers. And several weeks ago, she posted this: "My cousin in Trinidad won't get the vaccine because his friend got it and became impotent. His testicles became swollen. His friend was weeks away from getting married. Now the girl called off the wedding. So just pray on it and make sure you're comfortable with your decision and not bullied." So Nicki Minaj sent this out to 22 million people. And now we as healthcare and public health are gonna have to contend with COVID for probably another decade because Nicki Minaj's cousin friend took the vaccine and probably actually had chlamydia, but blamed it on COVID vaccine. And now we have to deal with the consequences of that, right? So, it's stuff like this where, in some cases it's malintended. In some cases, it's somebody interpreting a situation and wanting to be helpful, but not doing their due diligence, but then having a platform of social media that gets to so many people so quickly and really shapes public thought. There was actually a hilarious, and if there's nothing else you take from this talk, Google Stephen Colbert and Nicki Minaj, and you will see a hilarious rendition of one of Nicki Minaj's songs that speaks to this. So I hope you check that out. But I think it is really important in all three of those examples, the power and platform of social media in shaping thought and behavior is at a scale that it just never has been. And it's something that is changing the way that we as public health and healthcare in individual clinical settings, in institutional settings, and in our sort of mass communication and shaping of approaches, we've got to be aware of that. And I show this slide because there is this element of social media that is maybe not malintended, like I said, but there is an element of it that is very malintended and very intentional and strategic. And I think I want to bring a little light to that. There's an international think tank called the Center on Countering Digital Hate. They produced this report back in May of 21. And what they did was they took a snapshot of posts related to COVID across Facebook, Twitter, and Instagram. And of all of that COVID-related information, they determined what either fell into the category of misinformation or disinformation. And it turned out that 65% of that misinformation or disinformation emanated from 12 user accounts. 12 people advancing wrong information with the very specific desire to sow seeds of fear and doubt and push forward an anti-vaccination agenda. Now, it's not just the action of putting things on social media that aren't true, but the thought and the strategy behind it, because not only did 12 account users make that significant dent, but they also, paid social media influencers thousands of dollars to share and reshare the information they were putting out. And they created, they coded bots, the sort of artificial intelligence that would share and reshare. And so there really is a very specific and intentional strategy behind all of this that we need to understand, know that exists, and start to work against. So as public health, what are some of the things that we've learned in trying to respond to this? And just three basic ideas here. One, we've had to really evolve our communications. We've had to adapt our operations, and we've had to learn to trust our partners to get this work done. So I'll start with the evolving of our communications. Our efforts to date have been pretty traditional, right? We get on the local media, we put stuff on our website, we make flyers and we hand them out. And those work to varying degrees depending on what the topic is, but we've really had to think differently about those communications with the advance of social media. And we've tried some of that kind of pre-COVID, tried to get better at that over the last few years. And what we've seen is that as a governmental entity, our stuff does not land on social media the same way that other people's information might. And so I think there is a huge body of work that needs to be done here around how does credible information make its way onto here, and what are the strategies that we need to use to counteract the misinformation and disinformation that's happening. I think a lot of this also comes down to our local efforts, our local work, because our communications efforts can't just be credible information that goes on social media or on websites, but it has to happen through relationship. It has to happen through that provider-patient relationship. It has to happen through the institution-community relationship. And so many of our efforts started to shift gears to using our community health workers. So back to the example that I shared earlier about testing in low-income communities. Thankfully, we had years of presence through our community health workers, through providers that actually deliver services in many of those communities. And because of the credibility that those community health workers and the relationship that they were able to engage patients in individual or group settings to try to counteract that. Similarly, we've had a lot of physicians who have who've partnered with us to do a teletown hall for their patient panels, and really leveraging their relationship with patients and the trust that they have and credibility that they have with patients to be able to talk to 300, 400 patients at a time. To convey a message, to answer questions, and to engage in a different way that really just wouldn't be possible one by one by one by one. So we've really had to think about what are the different ways that we leverage relationship, trust, and credibility to communicate what we need to our communities. We've had to adapt our operations. So in the vaccination rollout, we did a lot of large-scale vaccination because part of the imperative early on was to get as many people vaccinated as quickly as possible. And so we had health departments and health systems, and then subsequently kind of mass vaccination efforts that popped up in convention centers, community centers. But we recognized that only reached a certain demographic, a motivated, informed demographic. And so our operations really needed to shift to continuing to do that, to provide opportunities for access, but also to doing much more tailored work in harder to reach populations. So going and doing pop-up vaccination efforts in those low-income communities, partnering with churches or other faith communities to bring vaccine on site, partnering with events like sporting events or other things that would draw crowds that we normally wouldn't have access to. And so we really had to think differently about what our operational model looks like and adapt that. And again, we relied heavily on our network of satellite clinics that we have in the Richmond Henrico health districts, our staff that live in and work in many of our vulnerable communities. And so I think there is something here that as an institution, we need to think about, that our patients aren't always going to come to us, that we really do need to figure out how do we have more presence, more trust, and more connection to the communities that we need to help shape thoughts and ideas around. And then we need to trust our partners. So even if we did those first two things incredibly well, there's still a reality that there are segments of our population who have history and legitimate reasons to distrust the government and to distrust healthcare institutions. And so we increasingly have to rely on partners who have more trust, who have more access, and who have more of a connection with the communities that we need to serve. I'll give two specific examples here. One is a church and community center in the Richmond area called Sacred Heart. And they have long been a go-to support organization for our predominantly Spanish-speaking community, and many of whom are undocumented and who aren't going to go to a website and put their information into a registration page to sign up for a vaccine appointment. They're likely not going to go to a pharmacy where they're being asked to show their insurance card, which they don't have. And so really, like, even if they wanted to get vaccinated, there were all of these systemic and procedural barriers that our systems presented for them. But Sacred Heart on the ground knows these residents, have them come to community activities, see them at church. They really did the hard work for us to call each and every one of their community residents, each of their participants, and not only to convey that information in language and substance that those residents could understand, but to put their stamp of approval and their trusted voice on that. And so, our vaccination efforts in predominantly undocumented communities really stalled until we effectively engage trusted partners on the ground that were willing and able to do the kind of work that we as an institution weren't as well equipped to do. Another example, I'll hold up my good friend, Dr. Rob Wynn, who is the director of the Massey Cancer Center at VCU. And Rob came to Richmond kind of right at the beginning of COVID. But one of the first things he did to try to start making those connections to the community was to create a virtual weekly meeting space for African-American pastors. So his work primarily in cancer, obviously lots of health disparities existing there in terms of stage of presentation, incidence of disease, et cetera, access to treatment. So he created this space called Faith and Facts Fridays. That started as just a small group of African-American pastors that would join every Friday. He would bring in speakers on different topics. He would bring in, and then as COVID kind of emerged, he would bring in different voices from local, state, and federal government to talk about what was happening with COVID, what was happening with the development of testing, of the development of vaccine. And over time, this group grew to about 150 pastors that were joining on a regular basis, and that had the opportunity to engage with national experts. Dr. Fauci even joined that Faith and Facts Friday at some point, but to really ask questions and talk about what they and their congregants would be facing and trying to sort through. And over time, a relationship was built, trust was built. And when it came time to vaccinate the community, those African-American pastors were some of our best advocates in the effort. They all wanted to get vaccinated on camera so that they could show their congregation that they were behind this. They wanted their churches to be places where vaccination efforts would come to make it easy and accessible for their congregations. And they talked about it. They engaged their congregations in meaningful conversation, asking questions, addressing fears. And they were able to do that because of that relationship, that trust. And we were able to leverage their credibility in the community to have rates of vaccination, especially in the elderly African-American community, who are largely the church-going community, that rivaled many other racial demographics. I think that really kind of points to some of the ways that we've had to act differently, think differently, and operate differently in this environment. So what's next? What does that mean for the ways that we need to think about this work moving forward? Again, 3 conclusions. There's 100 more, but I think these are 3 that stand out to us. One, that our workforce needs to look like the communities that we wish to serve. We need to hire residents of communities and honor them and hold them up for the expertise that they have. The community health workers have fundamentally changed the way that we do our work as a local health department. And the COVID funding really allowed us to expand from our core of 10 community health workers. We were able to add 18 more, where we're hiring residents from communities and really, again, relying on their expertise and credibility in their own communities. But this is true for clinical and institutional settings as well. We need to think about who are the patients that we need access to. Do we have physicians and nurses that look like the patients that we want to serve? Are our materials translated, not just in kind of, Google Translate language, but really sort of in cultural contexts that our patients need to understand and engage with? So our workforce needs to change as do some of the ways that we communicate. We need to change how we think about the social media influence. And this is one that I don't have a lot of answers and frankly, not a lot of optimism right now, just seeing what's happening in our society's reliance on social media for information. And as I said earlier, I think this is a place where we as physicians, as kind of credible purveyors of information, we've seen a younger generation of physicians really take to social media to use their platform in different ways to try to counteract what's happening out there. I think we need to see more of that. And then there are probably lots of strategies that we have not yet thought of about how we leverage social media, how we seed campaigns that aren't coming from institutions, but that are coming from more credible voices. And we've tried some of that with COVID, like we have done TikToks, we've done catchy videos, and seen some success. The initial response from that was like, yeah, that's cool. But it's not leading to the kind of, breadth of following that Nicki Minaj has. And so there's still a lot of work that needs to be done here. And then we have to be committed to this kind of work longitudinally. We really have to be in it for the long haul. And I think we have seen this as a local health department working with our public housing and some of our other low-income communities, having community health workers, having satellite centers. We've been at it for a decade now, and that has helped significantly in our trust with our communities. But I would say that a decade's not even long enough, given the decades and centuries that have led to distrust in marginalized communities. And so our institutional efforts need to be real, they need to be funded, they need to be significant and authentic, and we've got to commit that for the long haul. All right, so I will pause there. I know much of our discussion will kind of rotate around some of these issues, but thanks again for the opportunity to be here. This is great.
Thank you so much, Danny, for that. There's a lot to unpack here and a lot to discuss, which I'm sure we won't get through all of it. But before we open it up to general questions from the audience, both on Zoom and here in Penn Hall, just want to spend some time discussing some of these key points. There's just a lot to consider. And I want to invite Dr. Max Luna to start us off here with some of his own reflections going forward.
Thank you, Justin and Dr. Avula. What a pleasant and not surprising that it looks like we've been sharing the playbook for the past year. Him coming from the central offices, and we're trying to bridge that health disparities divide for the past year and a half. It is this vision and experience from our central offices in the state that we get and should demand policies, expertise, and resources to invest in mitigating historical health disparities, now exacerbated by our COVID-19 pandemic. Pleasantly, one sees good things happen after bad things, like our August 12, 2017, a crisis of health, racial justice, racial tension. We have come together to work and mitigate what has brought us then, and UVA Health, UVA at large, and Charlottesville community has responded robustly to create an environment of inclusion in Central Virginia. Same with health, in health matters. After 18 months of battling this health crisis and racial justice, I'm pleasantly seeing that our institution, and I was sharing with Dr. Avula that in this year, UVA Health has added a fourth mission to our main mission of patient care, education, and research. Now we have community and health equity as a main fourth mission in an institution. So there's a lot that we're gaining out of this. And we're thankful for leaders in our central offices in state, in our institution as well. What do I have to say when I hear Dr. Avula's perception of historical distrust? How do we respond, and what worked in Richmond, what worked in Virginia at wide? We at UVA Health, early on, we realized that we need to change the playing book early on. As you remember, in April, we said, we have COVID testing for you, just have your primary care physician refer you for a test. 50–60% of Latinx community don't have a primary care physician. 50% of foreign-born Latinos don't have access to healthcare. How are they gonna get tested? So early on, we discussed and debated how to mitigate this, and we made COVID-19 testing without referral. Within 2 or 4 weeks, we were testing on site and in the community to respond to these challenges in healthcare access. Another thing that I wanted to mention is that term of trust is a term that we use it widely, but it's critical to engage communities that have been underserved for centuries. So the luck that we had, and if not luck, commitment, is that we've been in the community for almost a decade, particularly in the Latinx community, building trust on cardiovascular prevention programs, cancer prevention education. We are building a Clínica Latina to serve people that really don't have access to healthcare. We have a robust and very active a group of community health workers. And prior to COVID, we were spending 70 hours a month in the community. And that was what we thought early on, the trust that helped us work on access to vaccination, taking on testing. Yeah, so that trust cannot be overstated in healthcare. And the other component of trust is we never talked about vaccine for the first 8 months, beginning and ending a conversation with an individual or a town hall saying this is a personal decision. That was before the mandate. We needed to make sure that we were thinking about them before thinking about us, about counting the vaccine in our roster of how many vaccines we got. We need to make sure that it was a decision that they were gonna bring home and come back and get vaccinated while they were listening and reading all those social media distrust, challenging messages. The other thing that I wanted to bring up and briefly, but critical, is that these messages land well in communities that have already centuries of mistrust and based on lack of access to healthcare, lack of transportation, lack of language and cultural competent care. Some of them come to UVA or come to other healthcare centers and they leave with their questions unanswered. So if there's a gap in trust, then the message from Nicki Minaj or anybody else, the show there that they enjoy, that's gonna land prime to misinform people. So that critical to that is that we need to recognize what are the key components of health disparities that each of these community members have and understand why the media feeds on them, but also understand how to act upon it, not only with information, but with the delivering vaccine, delivering information. For instance, if people work two jobs a day, they will not have time to come to a COVID vaccine center that's closed at 5 p.m. So when do we take the vaccine? Evening, do we take it in the weekends? So recognizing that each member or subgroup of the community has a particular health disparity that we all need to learn and keep it in our playbook. I want to stop here for now and see if Justin wants to get us in another direction.
Yeah, and thank you, Max. I mean, these words like relationship and trust and longitudinal commitments, I mean, they're all interrelated words and interrelated processes. And I wonder, you know, Danny, you used the word workforce, and I'm curious if you might speak a little bit about the workforce of public health. Early in the pandemic, one of the things that we were talking a lot about was how much or how we had underfunded public health relative to other aspects of our social structures in the United States in particular. And of course, now we're continuing to face profound workforce challenges, whether it's in medicine or public health. And it strikes me that, you know, relationship building and trust is a labor-intensive activity by definition. And so how do we bridge that gap? How do we move forward and think about how do we build not only our public health communities workforce, but also the workforce that is going to bridge between government and the communities themselves?
So I think part of the answer is that we've got to advocate for these things, right? So that work and the shift in workforce, that's not reimbursed by insurance, right? That's not paid for really out. We do a lot of that through philanthropic giving. We have local foundations that support the work of our community health workers. Increasingly, we've gotten local governments to say this is valuable work because it connects us to the community. But we need to, and I think COVID has done this to a large degree, is kind of put public health in a spotlight that it's really never had, right? Like even my own family didn't really know what I did before COVID hit. And so I think what is true and what will continue to be true for the next few years is the federal government grappling with, okay, now that we understand the role of public health a little bit differently, what do the models need to look like, and what do we need to provide sustainable funding to be able to ensure that institutions have trusted relationships with communities. I think the same is true for healthcare, that we need to incorporate more social workers and more community health workers and more staff that reflect the communities we need to serve, and that we're gonna need to make financial commitments to prioritize that. But I think that is more in the limelight than it ever has been.
Max, do you have any thoughts on that?
Yes, I agree. And statewide level and institutional level as well. We think that it's not only what we do in the community, but where we go for it, what time we do it, and particularly who does it. And Dr. Avula speaks about the language and cultural concordance with community members, same with patients. And that's how we at UVA, we're striving to diversify our workforce. We need to prepare for our demographic changes. As you all know, Virginia is a growing state on immigrant communities, and we will be mistaken if we do not prepare for a demographic change where our Latinx community doubles or triples over the next 10 to 20 years. And in order to respond to that and cherish that and welcome that and celebrate, we need to be prepared with language and cultural competence workforce. And we need to work on pipelines to recognize we were there for COVID-19. We were there for August 17, 12. We're now here to plan our future together.
I want to add one more thought that Max made me think about. This really sort of gets at the essence of health equity, right? We talk about the concept of equity, and I think it means a lot of different things to a lot of different people. But at root, at least through the public health lens, what we're talking about is addressing the systems and structures and creating the opportunity for all people to be healthy, regardless of their circumstances. And inherent to that is the reality that this is going to cost more. It's going to require more resources, more intentionality to be able to provide access and change systems and change the environment for our vulnerable populations. And, as I talked earlier about the racial reckoning and kind of this period in history, and the fact that we hear equity more than we ever did in kind of the public conversation, that's a moment we've got to continue to lean into and recognize that these are going to require significant financial investments to achieve true equity.
Yeah, and I invite our Zoom participants, anybody in the audience, in the live audience who may have a question, to go ahead and enter this. We do have one question that's come in through Zoom, which I think is very much a part of our discussion here about workforce. The question is, in response to the challenge to meet the community where and when it is at, is there a need to adjust or restructure the workday or the work week of the healthcare workforce, of the public health workforce, to enable them to work on weekends, evenings, et cetera, rather than depend on these professionals to donate their time and volunteer? Thoughts on that?
You want to take it, Max?
Yeah, I know where this is coming from, and I agree. We leave a lot of people behind after our doors close at 5. No wonder why we see some unnecessary ER visits at 10 p.m. with an ear infection, because the morning after the phone call is answered and say, yeah, we will take you at 3 p.m. and the day after tomorrow at 3 p.m. They're trying to catch the bus for their second job. So it is something to reflect. I agree that charity work is not the way to respond to health disparities. Charity work, as you all know, disappears in a moment of crisis. In funding for foundations, time of foundations in the community disappears when we are all naturally caring for our families and or our particular needs. So there are needs of structural changes, institutions, statewide or institution-wide, to find schedules that adapt to our community needs. Those require investment and commitment.
Yeah, couldn't agree more. And I think it speaks to my second point about adapting our operations, right? Like this is one of the clear ways that we think differently about where we are and when we are to organize what we do around the unique needs of the communities we're trying to serve.
So I want to ask too, in this context, that one of the things that we're hearing more and more, especially now multiple months into vaccination campaigns, we're hearing from various primary care societies across the country, as well as local entities, about a desire to integrate vaccination more into primary care and primary care clinics. And of course, there are some challenges to that, including storage and things like that have been part of the sort of more top-down campaign of thinking about how best to get a lot of people vaccinated in a short period of time. But are we in a different moment now, Danny, where we can think about how, insofar as we're continuing to integrate with our community organizations and going to communities where they most need us, how do we also then leverage those longitudinal relationships of primary care, the longitudinal relationships that are often very bound by trust, and to think about other vaccination campaigns reaching individuals?
Yeah, this is definitely one of the biggest challenges of the vaccine rollout was, the frustration of frontline primary care providers who just wanted to serve their patients. They wanted to be part of the macro effort to contribute to the health of our community, but they also had patients who were calling them every single day, and the feeling of not being able to respond to that and need that. And so I met with so many, like all of the medical societies across the state, so many different times to try to keep docs in the loop and help them understand where we were with vaccine supply and kind of at the front end of this. There were logistical issues, right? Most of the frontline healthcare providers and nursing homes, like that was the 1A population. And so most of the vaccine went to health systems and congregate care settings. As it started to come to health departments and providers, we did want to ensure that we could get to as many people as quickly as possible. And so that concept of efficiency kind of ruling that specific period of time was really important, even though it was really frustrating to a lot of my primary care colleagues. And so, we had to navigate a lot of those conversations and totally understand where primary care is coming from on this, because they do have the trust of their patients. They do have the ability to kind of talk through specific scenarios and help their patients make a decision to get vaccinated. And what I told a lot of our primary care providers at that stage, this is kind of March, April, February, March, April, was that your time will come. Like, we will absolutely need primary care, especially for the vaccine hesitant, because you all will be able to reach that patient population in ways that public health certainly cannot, that pharmacies have less of an ability to do. And I would say, that really kind of April, May, when we started to see the flood of vaccine come in, that's when we really started to shift gears and say, okay, there's plenty of vaccine. We can do both the high volume, efficient route and get it to providers. It was interesting because a lot of the red tape that providers had to jump through, they had to sign up through the CDC as an approved provider. They had to ensure that they could deal with all of the cold storage issues. And we had a lot of providers that actually dropped out. So I guess the takeaway is that we've got to think through a lot of this on the front end, and hopefully there'll be a lot of learning that comes out of the vaccine rollout with COVID that will prepare us for a more integrated public health and primary care approach in the future, because we can't do it without each other. Primary care plays such a crucial role, and I certainly see this at this stage of the vaccination effort, but that if we had more vaccine supply, that would have been true at the front end as well.
I agree. I also, in February or March, in my cardiology clinic, everybody was a high-risk patient. Everybody, I saw them with a vaccine in their forehead saying, this is a person who would love to have access to vaccine today. And it's interesting because this morning, we did in my AM clinic, we gave 5 flu shots. And we are not primary care docs, but we take on the opportunity to vaccinate for flu. Could we, in the future, hopefully we're not going to do COVID vaccine every year for the next decade, but find ways to get them to the clinicians where the trust lands, without forgetting that there's many people that don't have time or access to a primary care doctor who could give them a vaccine. So a multi-pronged approach that includes community-based, wide-based vaccination, and clinicians may be the way forward.
Thanks, Max. We have time for maybe 1 or 2 more questions. If anybody in our live audience or through Zoom wants to ask a question, please feel free to type it in, or please feel free to stand up, and we'll provide you with a microphone here. The other aspect of this is underfunding social services that generate profound inequities, on which our sort of public health and medical challenges unfortunately find themselves stuck. So, there's the common refrain in American healthcare that we spend so much money on medicine, but we don't get enough good outcomes out, from that spending. But as I know we're all aware, and many of our participants are likely aware, that there's also an argument that we don't spend enough on social services relative to healthcare, and I would include public health within social services in that context. So how has the experience in public health for you, Danny, shifted that conversation in terms of what we think about as a society, and how we really build out all of our services for those who most need them?
Yeah, I think there's more attention to this than there has been at any point over the last 20 years of my career. And I think part of that is a recognition of the role that social determinants play in health outcomes. And as more and more clinicians and public health practitioners understand this, operationalize this, we're seeing new models both for service delivery, but also for financing of healthcare emerge. And so I think what we will continue to see over the next few years is a real shift towards more value-based payments, where we're looking at bundled services. I'll give the example of pediatric asthma. We've done some work to recognize that part of improving pediatric asthma outcomes is better clinical management, right? Managing to guidelines. Part of it is helping support patients in medication compliance, but there's also a large environmental component here. If there's a smoker at home, if they live in a moldy house, if they live in a house that's pest infested, with cockroaches, since that's a big trigger for asthma exacerbations, that there are environmental interventions that actually will have huge implications in reduction of hospitalizations and ER visits related to asthma. And when we can start to bundle pay for that suite of services, we will see the improvement in more severe outcomes that we need to. So I think that's one example of many where we'll see the financing of healthcare services to include environmental and social supports. That'll just become more of the norm. But I also see it in the actual operations of the way that practices are evolving, the recognition that we do need to do more home visitation utilization. Now that we've got telemedicine actually being paid for, I think that opens up huge opportunities to have this kind of spectrum or continuum of the way that we engage with patients. I think there needs to be an increased commitment of funding to those home visits, to social workers, to all of those other supports that need to happen. And then the other thing that I see happening right now, right in the state of Virginia, there's some movement around something called Unite Us. Unite Virginia is the branding of it, but it's basically a coordinated care case management platform that a lot of the social services entities and public health entities are starting to use. And I think that speaks to this recognition that we are touching the same patients. We're doing a lot of different work, a lot of different eligibility, determination, establishment with the same groups of individuals and families. And we've got to, for outcome's sake, but also for the experience and dignity of the patients we're trying to serve, we've got to find more honoring ways to do that. And it means we've got to build muscle across disciplines to do that kind of coordinated care for families.
Max, any thoughts on that?
No, just to say that that approach will not only mitigate human suffering, but it's fiscally responsible. We will decrease unnecessary ER visits if we have a network of organizations in the community to decrease exposure to risk, that it could be injury versus violence, a healthy lifestyle, healthy eating, decreasing food deserts. Deploying that in the community will decrease that unnecessary use of healthcare resources. Secondary, first is mitigating human suffering, right?
Well, thank you. I want to thank, we're out of time, unfortunately, but I want to thank everybody for participating in today's Medical Center Hour, and thank Dr. Avula very much and Dr. Luna for these critical conversations, which I know we will continue to have over time. A reminder that for eligible attendees, you can claim continuing education credit for your participation today. And please join us next week, same time, same Zoom link, and this will be a Zoom only presentation for Professor James Nolan, who will be discussing his extraordinary book, Atomic Doctors, Conscience and Complicity at the Dawn of the Nuclear Age. Next week's event is co-sponsored by the Historical Collections of the Claude Moore Health Sciences Library and UVA's Institute for Advanced Studies in Culture. Thanks everyone so much, and we'll see you next week.